So Penny, I'm going to start with you because we had a few questions come in about the cushions. I'll just take them, there's 3 here, and I'll start with the first one. What do you wash the J cushions with? Would Precept wipes work?
Yes, you can use Precept. It was one of the things I forgot to mention. When you're using Precept, and you can use them on the Roho cushions, you can use them on the J's, what you should do is wash them, and with the Precept, let it dry for about 10 minutes, and then take a nice warm, wet cloth, and then just wipe them again with the just clear water. What that does is it takes that film back off, because what happens if you leave that on the covers or on the Roho sections, or even on the bed, there's a Roho cover that goes on there. If you leave it on without washing it off, as soon as it's warm, the moisture from the patient, it will disintegrate those cushions and the covers. So it's really important after you use the Precept to just rinse it with some clear water. Now, if you just want to throw, what we do at Parkridge, we sometimes just throw the Rohos into a tub, and we just use soap, like dish soap, something mild just to wash them off with, and that should be good. And then just rinse them off and make sure you dry in between each of the cells.
Okay. Great, thank you, Penny. And another question is, how often should inflation of cushions be checked, and who checks them? Should it be the family or the nurse?
It's probably best if the nurse checks them, because family may not do it correctly. And I think the more familiar you get with checking them, the easier it is to make sure that there's enough air in them. So what we would, well, every day you should check them, because there might be a hole in one of the cushions. So don't wait until they're completely flat. Now, sometimes they look flat when you actually try and put your hand on them. So, because what you're doing is you're pressing all the air out and it's going to the outer section. So if you have the person in the chair, check them at least once a week, so that you can determine whether they've lost some air, or if the person is complaining, or if you see some red areas. So yeah, I don't know if they can do that once a week, but it's probably best if you can.
Okay, great, thanks.
And if you have an OT, they will come and check them for you.
Great. And that's the team that Donna alluded to. And here's a question, Penny, how do you put air in half the cushion?
Well, you wouldn't just put air in half of the cushion. You'd have air throughout the entire cushion. So you would put the air in the cushion to start with. I think they're probably talking about the Quattro. And so what we would do is you put the air so it's even all over to start with. And then if you just want more air on one side of the cushion than the other, then you would get them to lean on the one side you want less air in, so that the air will go out into the other part of the cushion, and then lock it in. If you just want air out of the, sometimes we put a little bit more air in the front of the cushion than in the back, just because you don't want them sliding. So you could put them in a little bit of tilt if they're in a tilt chair to start with, and then and unlock it, and then see how much air is in there, so the air is actually going into the front, and then lock it in. So I hope that answers that.
Great, thank you, Penny. I'm just going to move to Donna. We had a question come in before the break. I'm just getting to it here. Angela Graham sent us a question by text. I'm not sure what part of the province she's from, but she's an advanced care paramedic in the community. They do not carry specialized non-adherent dressings and are often asked to do wound management. What can Angela use for skin tears that will stay on the skin for 14 days?
The only thing that really can stay on that's manufacturally recommended for a 14-day wear time is the Mepitel. So I'll hold that packaging up so Angela hopefully can see that. This is called Mepitel 1, just means it's sticky on one side, but it's the Mepitel dressing that is the only one that has the capacity to remain in place for that length of time.
Okay, thank you, Donna. Here's a question that came in, it was called in during the break actually. So the caller identified, Donna, that they have a patient who has a healed pressure on a heel, H-E-E-L, heel, with a small dry scab remaining. The skin on the heel itself is very dry. They are using boots and floating the heels. The question is, should they be using betadine to dry the scab or a lotion such as, you'll have to help me, attractine to keep the surrounding skin moist?
Okay. It's a challenging question to ask without knowing the caliber of the circulation to the foot. If there are pulses in that foot, generally there's at least some circulation to the heel, and of course you're going to be palpating the posterior tibial pulses behind the medial lateral malleolus, because you need to know about heel blood flow. If there is marginalized blood flow because you've been told that, or the individual has had some kind of testing, or they're pulseless or minimally pulsed, then you would dry that out. You can dry it out with either betadine or chlorhexidine and leave it air dry, and then you do cover things with gauze to allow air to continue to circulate. You're very correct that attractane deals extremely well with dry skin, but in that instance, if you want that scab to remain intact for protection, you wouldn't want to use that attractane close to the edge of that, because it would soften it up.
Okay, and another question by text, Donna. Excellent presentation, I would totally agree. There's some confusion with the Adaptic. The manufacturer's instruction says it can be left in place for several days and up to 7 days, depending on the amount of exudate. Could you clarify why it should be changed after 24 hours?
That's just because that's what I used to do, and I haven't actually used it in practice for a while, and that's why we use manufacturer's directions. So if they tell you it can be used for several days, then feel free to do that.
Okay.
Thank you for clarifying.
And then I have a question I'd like you both to address, and then I'm going to come back to you, Donna, for some really kind of clinical questions. Let me find the question. Has there been much use of bioelectric healing devices for healing pressure ulcers in the Saskatoon Health Region? Now tell me, I don't know what bioelectric healing device is, so that's why I'm asking.
There are there are some electric conduction devices. Sorry, all of a sudden got a frog. There was a trial being done in rehab at City Hospital as well as home care a few years ago around electrical conduction. And it was because it was being presented nationally by a physiotherapist, actually a physician, a doctorate of physiotherapy who had used that same technology in London, Ontario, and pressure ulcers with good success. We did a trial. I'm not sure that it currently is being used at all. I don't think that we actually had much success in finding the appropriate candidates.
Okay, Penny?
No, we don't. I've never used any, and I don't know of anybody that has.
Okay, can you, I mean, you don't need to put a lot of detail. What's sort of the science behind using the bioelectric device?
Wakes up the cells. What happens with chronic wounds over time is your body becomes very happy with having a defect, and you get something called senescence. And so the cells become senescent. They basically just go into sleep mode. And so things like electrical conduction actually wakes them up, because all of our cells have an electrical current.
Okay, so that's the reason for
Yeah.
trialing it.
Mm-hmm.
Donna, there was a question about packing a wound and undermining and what types, and I think you addressed that in your presentation, but one question I had was, how do you know when to stop packing a wound?
Basically when it's not as deep as it is wide, and I'm serious. If you've got a wound that's this big, okay, and it's this deep, you can stop packing it, because it's going to fill up from the bottom before it comes in. The reason for packing a wound is to stop it from prematurely closing and forming an abscess. So if it's got a lot of depth and not a lot, and then you have to bring it up from the bottom first, so you put something in there to stop premature closure. But once it gets to that level where it's, it's actually quite a diameter and quite shallow, you don't need to pack.
Okay.
I hope that answered it.
Sorry.
I said I hope that was okay, answers it.
A question about cleaning. So when you're cleaning a wound, prepping for a silver dressing, do you recommend saline or sterile water?
The manufacturers, again, will tell you that you can cleanse the wounds with saline. They activate some of the silver dressings in sterile water or in water. They've actually used tap water to activate if you've got really good source of well-cleaned water, that you can actually use tap water to activate them. And it's the activation process with the Acticoat. That's the only dressing that sterile water is advocated for in, and you can use Intrasite in combination with Acticoat as well, and Intrasite is essentially a gelled saline, but the company manufactures both those products and have found that they actually can be used together.
Okay. And I have another question here about comorbidities, I think. What suggestions, and Penny, you could chime in on this as well, what suggestions do you have for management of wounds or pressure areas as a result of suspected arterial insufficiency?
Okay. Well, pressure ulcers are caused by pressure because the pressure causes ischemia. If you have someone with an arterial wound, they already have ischemia. So basically all you can do is revascularize them if there's an option, because nothing else is going to solve that problem. You have to deal with the source of the issue.
So offloading is, it depends where they were looking at. If it's a heel, you want to offload it. If it's a coccyx, then you can offload it with the enhancer cushion that we talked about. So you really want to not have any of that pressure on that ulcer. So.
Mm-hmm.
So that would be like using the device to float the heel and
Yeah.
Mm-hmm.
yeah.
The Prevlon boots.
But when you think about arterial wounds, they're typically peripheral. They're typically on the feet, right? The farther from the heart, the more likelihood of arterial compromise. So that's so when I'm thinking of that, if it's probably on a heel, I'm assuming, if it's pressure related.
Okay.
Yeah.
Okay. And can I ask, just from my own practice, when you're offloading pressure on a heel, because I've actually seen this in my clinical practice when I've come on shift, how do you avoid putting pressure somewhere else on that limb because you're offloading pressure on the heel? You know what I mean? Like you're suspending the limb and then you get a pressure area there.
You can. The biggest thing, I think the worst thing is that we traditionally, because we didn't often have other options, was to raise the foot on a pillow and drop the heel off the edge. But when you're doing that, you are raising the entire limb. So you are increasing, you can have the potential to increase the pressure on those ITs. What you don't want to do is raise the head of the bed in conjunction with that, because now you've sandwiched them and all the pressure's right here. But if you actually use a proper heel boot, it actually is rounded out around the heels. So if you use the Hollister boots, help me out here, they have a little indent that actually allows for lessened pressure, and just kind of that part is more of a frame that digs into the bed and keeps things minimally, keeps things elevated. Or the Prevlon boots that have it just kind of raises it down the limb rather than suddenly. Does that make sense? Like
Yeah,
putting a towel or a rolled towel behind their heel is where we used to get pressure problems, right?
Okay.
Yeah.
So you're offloading the entire leg, really?
Right, yeah. Because I think practices have improved since I was a new graduate. There's been a lot of improvement in that area. I wanted to ask a question from me about the Braden scale, because you mentioned, both mentioned the Braden scale. And of course the Braden scale is an assessment tool used to assess the integrity of skin and identify any issues with that. So Donna, you talked about using the Braden scale as a first assessment and then subsequent, so subsequent care providers can know what's going on with skin or a wound or an area. And Penny, you talked about the Braden scale as being a tool that's used to access the proper equipment. So I wonder if would you be able to just comment a little bit on the process? I wasn't aware that the Braden scale was need to be used for access of equipment because I've never accessed the equipment, but maybe you could start, Penny, and just talk a little bit about that process.
Okay, so what we do is we look at the Braden scale, and it's the scale is only as good as the person that's doing it. So you really have to be honest and look at the different areas. And I don't have one in front of me right now, but one of the areas is moist skin. And I know a lot of people say, well, no, they're not very moist. But if they're incontinent, they have moisture on their skin. And when I was doing the Braden scale one day with one of the clients, I asked one of the care aides about, is she moist a lot of the time? And they said, no, she's never moist. So then I went out into the atrium just to look at her. She had this huge puddle underneath the chair. So she'd been sitting in this incontinent pad for a very long time, so much so that the T-foam cushion was completely soaked, and there's a huge puddle under the floor. So you're only as good, like the Braden scale is only as good as the person that's actually doing the scale. So what I like to do is when I order a cushion, I actually talk to the nurse about how much they're eating, and so I need to know that. And I also look at moisture. I look at all the areas, and I don't go off the Braden scale. It's in the chart. I do my own Braden scale, so that I know exactly where the issues are, and I can accordingly assess it and see what the scale is. Now, it'll tell you at the bottom, you're at risk, high risk, you're at moderate risk, you're at low risk, but sometimes you already have a pressure sore and you may be at low risk. So it's, you have to look at that, but you also have to look at what's really happening with the client as well.
Okay, thank you.
If you have a pressure sore and you've been scored low on the Braden, I'm going to challenge you as to the accuracy of the assessment. The biggest things to recall is the Braden scale is a risk assessment tool. So it's identifying risk of pressure ulcer formation. So when you look at those parameters, if you don't know if they eat more than a third of the food on their plate, score them low. A low score indicates higher risk. It should increase your attentiveness to that. It should be it's the best way of documenting a concern. You can always adjust as you go through, but you never score high. We're not trying to win a race here. We're trying to identify if somebody has a potential problem. And 13 or less means that you're at quite a high risk. 11 or less means that you basically need to be on one of those very fancy support surfaces or in the tilt chairs and all those other things. The lower the score, the higher the risk.
So the Braden scale is a good validated tool, and it's most useful if it's applied consistently and accurately through objective and subjective assessment.
Yes.
Okay. And I really appreciated your information about the role of pain and the need for assessment, and particularly the challenges of assessing people who are maybe not vocal or who have issues with dementia or delirium. And I know from other sessions we have done, the Saskatchewan Professional Pain Group for Pain Management, Professional Practice Group for Pain Management, does have a website at SASK, S-A-S-K, I have to look now, SaskPain, S-A-S-K-P-A-I-N, all one word, .ca, and sorry, it won't, oh, it is there on that's great. So you can go on that website and click on resources, and you will see, get a link to tools that can be used for different types of patients, clients, and residents, and information about what's being done elsewhere too. So I don't know if you have anything to add about that, Donna, about assessing?
No, but a lot of times when we're dealing with wounds, and I'm probably as guilty as anybody is, we do negate it because it is an intervention, and a lot of people react to interventions. And so one of the biggest things is, are they pulling away? Are they grimacing? Are they crying out in pain? Those are all indications that there is significant pain and that we need to address it. And far too often, pain is undermanaged, especially in the elderly, and I'm going to say especially in people at risk of falls. And pain can contribute to all kinds of other events like delirium. Like an acute delirium is a medical emergency. And I actually had a situation in one of the hospitals where a family member came to the desk, said to me, my mom isn't getting her getting her medication for her arthritis. She's been on pain medication, a low-dose fentanyl patch, for 15 years, and she seems to be more confused. So I actually spoke to the physician and said, you know, I think that the pain that she's experiencing currently is contributing to a delirium. And the doctor said to me, well, I stopped it because she had a fall before she came in. I said, she's been on it for 15 years. I really don't think that this probably contributed to this fall, and I would like to see if we could reinitiate it and see if it made a difference, and it did. She'd been off it less than 72 hours. We put the lowest dose of fentanyl patch back on, and the delirium turned right around. So don't negate pain. It can cause actually other huge issues in individuals.
Well, thank you, Donna, and it's certainly your final statements are a good wrap to what you and Penny have been presenting this morning, that it's about the whole person. There are many things that contribute to skin and wound, both integrity and to skin breakdown, and including thinking about the whole person, not just the dressing, not just the cushion. So that's very helpful.